Hello everyone, good afternoon. I'm Dr. Rohan Khandelwal, your Marrow Surgery faculty, and welcome to this first session on the potential questions and the important topics from surgery which you should know for the FMG exam. So I'll be conducting three sessions where I'll be covering up the entire surgery, and I'll be telling you the important topics which you should focus on, how to go about revising in the next month and a half now that the exam has been postponed, and the important questions which you should definitely revise a day or two before the exam. So now that the exam has got postponed, please don't let your guard down. A lot of times I see when the exam gets postponed, you people tend to waste 1 or 2 weeks. Don't make that mistake. Each day is crucial, and we don't know if when the next exam gets implemented. So you have limited opportunities in cracking the FMG exam. We know this time the FMG exam is occurring. Maybe we have another FMG session mid-year next year, but after that we don't know whether any FMG exam will happen or not. So please don't leave it till the last moment. This is your best opportunity. Make use of this postponement and make sure that you crack the exam. Keep on studying every day. Don't waste any day. If you're having an unproductive day, just do some questions, just revise previous year questions, but don't waste the day. That is important. Okay. So I have divided it, topic wise. First, I'm going to do general surgery, then trauma and burns, and then endocrine today. And before each, I will highlight this important topic list. So if you want to click a picture, please feel free to click a picture or make a note of these important topics from general surgery, which you definitely need to revise before the exam. Right. So in general surgery, I told you the topics. Let's start with the first question. So the first question is, while inserting a central venous line through the subclavian vein, a patient develops sudden breathlessness and absent breath sounds on the right side. What is the most likely cause? Very good. Pneumothorax is the correct answer. Excellent. Very good. Good guys. Pneumothorax is the correct answer. Absent breath sound, sudden breathlessness. So subclavian vein, most commonly pneumothorax will occur. Most commonly pneumothorax is going to occur when it is going to be through the subclavian route, right? So if you're inserting a central line through the subclavian route, pneumothorax most commonly can occur there. But you should know subclavian central lines, there is least risk of infection. There is least risk of infection and displacement in a subclavian central line. So least risk of displacement is with the subclavian central line as well. Please remember that. Now, this has been asked in the previous year FMG exam, right? Most common vein in which we insert a central line is the internal jugular vein. Least infection is with the subclavian. Maximum infection, Chris, you're right, is with femoral vein insertion. That is correct. Most common vein, Aishna, is IJV. Most common vein where central line is inserted is internal jugular vein. That has been asked in your exam. This is a PICC line. This is a peripherally inserted central catheter. Whenever we insert a central line, please remember that the tip of the central line lies in the superior vena cava just above the right atrium. That is the right position for the tip of the central line. It is superior vena cava just above the right atrium, right? We don't put it in the right atrium, otherwise arrhythmias will occur. So SVC just above the right atrium, and we check this with an X-ray. So cannulas are super important. There will always be a question from cannulas. You should know about this. Please, this is something which you should definitely revise a day before the exam. IV lines, you should know the color coding. Yes, what is the color coding of a green color cannula? Green color, very good. Good guys, excellent answer. Correct. 18 gauge is the correct answer. 18 is the correct answer. So you should know the color coding of IV lines. Orange is 14, gray is 16, green is 18, pink is 20, blue 22, yellow 24. right? You should know this color coding. I would go a step further because in two exams last year, the flow rates were also asked in the exam. So I want you to remember that wider the cannula, right? Wider the cannula, faster will be the flow rate, and narrower the cannula, slower will be the flow rate. Okay. So please remember the flow rates of orange, it is 240 milliliters per minute, gray is 180 milliliters per minute, green is 90, pink is 60. These four flow rates, please remember for the FMG exam, right? Please remember these flow rates for the FMG exam. They are very, very important. Every time you will get a question for from IV lines. This is superficial thrombophlebitis, which is the most common complication of IV lines, which you should know about. This I just told you. What is the best method to check the correct placement of a central venous catheter in the IJV? How do we check if the catheter is correctly placed? Very good. Excellent. Excellent, guys. Yashu, Divya, excellent, Achal. Chest X-ray is the correct answer. Chest X-ray is the correct answer. And I just told you it lies in the superior vena cava just above the right atrium. What is the most common complication after daycare surgery? So daycare surgery is when the patient is admitted and discharged within 12 hours. So within 12 hours, the patient is admitted and discharged from the hospital. That is called daycare surgery. The most common complication after daycare surgery is post-operative nausea and vomiting. Is post-operative nausea and vomiting. Sometimes they will just write PONV. PONV is post-operative nausea and vomiting. That is the most common complication after daycare surgery. Please remember that. This has been asked in the exam. Okay. Another very important question are surgical positions. So surgical positions also in the FMG exam, lots of times surgical positions have been asked in the exam. Yes, what is the answer for this? Correct, some of you are right. This is the Fowler's position. This is the Fowler's or the sitting position. It is Fowler's or sitting position, and this is used for CNS surgery. It is used for CNS surgery, especially the posterior fossa, because it gives good exposure. You get good exposure. So it is used for CNS surgery, posterior fossa. But the drawback, what is the drawback of this Fowler's position, please? What is the drawback of Fowler's position? Guys, what is the drawback of the Fowler's position? There is increased risk of air embolism. There is increased risk of air embolism. Okay. That is the drawback of Fowler's position. So that is the drawback of Fowler's position, which you should know about. Okay. These are the various OT positions. Again, in that important topic list, I've mentioned that it is extremely important for the exam that you remember these OT positions. Lots of questions have been asked. This is the supine position, which is the most common position, which is used. This is the lithotomy position. Lithotomy position, a question which has been asked is which nerve can be injured during lithotomy position. It is the common peroneal nerve. You will see one trend which is being asked in the surgery exam are nerve injuries. Invariably, two questions will be from nerve injuries. Mainly, they are asking it from thyroid surgery, from breast surgery, so you should, or from head and neck surgery, parotid surgery. So you should know about these nerve injuries which are associated. Make a list of it. That would be helpful for you for the exam. Okay. I've also made a reel regarding this on my Instagram handle, left-handed surgeon. You can watch those last-minute revision reels as well. They will cover up a lot of questions for you as well. So common peroneal nerve can be injured. This is the lateral or the kidney position. This one is the prone position. This one is the prone position, and the prone position is used for spinal surgery. The prone position is used for spinal surgery. This is the jackknife position. This is the jackknife position. The jackknife position is not used now. Why don't we use the jackknife position now? Why don't we use the jackknife position? So we don't use the jackknife position these days. Very good. Abhinav, the only way to remember this is to revise this. That is why these last minute, the important topics which I've told you, you have to revise them in the last 1 week so that it remains fresh in your memory. Positional asphyxia is correct. Very good, guys. Jackknife position is not used because of positional asphyxia. Excellent. Excellent. Very good. Okay, this is a very common question which is asked in your exam. So one question from sutures and knots is definitely asked. One question is definitely asked from sutures and knots. Which of the following is not an absorbable suture? Is not an absorbable suture. So polyglactin is vicryl. Polyglactin is vicryl, which is absorbable. Polyglycoperon is monocryl, which is also absorbable. PDS is also absorbable. PDS dissolves in 180 days, right? So the non-absorbable suture is polypropylene. Polypropylene also goes with the name of proline, also goes with the name of proline. So such kind of questions are frequently asked. One question from sutures and knots is definitely there. So this is regarding absorbable sutures. Absorbable sutures can be divided into natural and synthetic sutures. Natural absorbable are catgut, which is derived from sheep submucosa. This has been asked few years back. This question has been asked in the exam. Chromic catgut can also be used. Synthetic absorbable sutures, monocryl. Monocryl is polyglycoperon. And very important question, monocryl is used for subcuticular suturing. It is used for subcuticular suturing. This has been asked many times in the exam. Please make a note of this. Monocryl is used for subcuticular suturing. I will request the team to keep the video. They will share a link which you can utilize it to watch it later, but I would recommend that you listen to all the questions because I cannot promise that I'm not conducting this session, so it'll be better that you um, watch the video. Okay, I'll request the team to keep the video. So vicryl is polyglactin, and this is a braided suture. This absorbs in 60 to 90 days. PDS, I've already told you. PDS is polydioxone, 180 days. These are the non-absorbable sutures which are there. Non-absorbable sutures, you can have silk, which is a natural non-absorbable suture, and you can have synthetic non-absorbable sutures like proline. Proline has been asked multiple times in the exam. Proline is used for rectus sheath closure, right? And you should know that minimum length required is 4 times the length of the wound. This is known as the Jenkins theory. It is used for vascular repair or anastomosis, and the mesh material is also made out of proline. Nylon or ethylon is also a non-absorbable suture. Okay. Right. Okay. Foley's catheters, very important. This time in the INI CET exam, there was a question from Foley's catheters. You can also get a question from Foley's catheters. Milan, I just highlighted the important topics. Like I said before, every topic I am going to highlight the important topics, right? So from general surgery, these are the important topics. Please make a note of them, right? Similarly, before trauma, I'll highlight the important topics. I will highlight the important topics. Don't worry. Please make a note of these important topics. These you should definitely remember. So Foley's catheters, you can definitely expect a question. 14 grade Foley's is 14 French is green in color. This is true. The best way to deal with the stuck Foley's is ultrasound guided puncture. In a male patient, if the foreskin is not reposited, then it can lead to phimosis. That is false. It leads to paraphimosis. And three-way Foley's is used for clot retention. This is correct. Okay. So it leads to paraphimosis, not phimosis. Please remember that paraphimosis. Very good. You people are correct. Now for Foley's, please remember, you just need to remember green is 14, orange is 16, red is 18. Just these three you need to remember. Don't remember all the color codes. Just green is 14, orange is 16, red is 18. Just remember this much. The question which was asked in the exam, what do we mean by French in Foley's? French is the outer circumference. It is not the diameter, it is the outer circumference, that is 2 pi r. Please remember that French is outer circumference, or 2 pi r. Yep, that's a good mnemonic. Osteosarcoma. Gori is a nice mnemonic, which you can remember 14, 16, 18, 20. That's good. You can remember it using that mnemonic. Okay. Very, very important question. Prevention of wound infection is asked every year in the exam. Two questions. One, what type of wound, and how to prevent wound infection. You should definitely know this. So all the factors which are related to wound infection are very important for your exam. Right. Best time to give prophylactic antibiotics. Excellent. All of you are correct. 30 minutes to 1 hour prior to surgery. Very good. Excellent. So please note down, these points are extremely important. Prophylactic antibiotics, 30 minutes to 1 hour prior to surgery. Repeat dose in case of prolonged surgery. If the surgery is lasting for more than 4 hours, we will give a repeat dose as well. The other methods to reduce wound infection, the best method is hand washing or hand hygiene. Hair removal, please remember, we don't do shaving now, we do clipping of hair. We will do clipping of hair. So please remember that as well. So this is another type of question which you can get. What is the SSI? SSI is surgical site infection rate in a clean contaminated wound if antibiotic prophylaxis is used. If we are using, yes. So this clipping question has was asked in the June exam, and I'm telling you, every time questions are asked from wound infection. So two questions are definitely asked. So I'll tell you two tables and one image which you definitely need to remember. So this is one table which I want you to remember. This is a table from Bailey. Everyone should remember this table, right? This table will give you one question guaranteed in the FMG exam. So clean wound is when no viscous is opened. It's a clean surgery. The risk of wound infection is 1 to 2%. Whether you use prophylaxis or you don't use prophylaxis, it is 1%, right? It is 1%. Right, so they've posted that you can watch the video will be saved, you can use the same link and you can watch the video later as well. So my humble request would be that try to answer the questions and try to understand the concepts. You can always visit the video later and revise. Okay. Clean contaminated wounds, when the viscous is opened, there is minimal spillage. When if antibiotic prophylaxis is used, 3% is the risk. Without prophylaxis, it is 6 to 9%. Without prophylaxis, it is 6 to 9%. Contaminated with prophylaxis is 6. Without prophylaxis is 13 to 20%. Dirty wounds are those where there is perforation or we are draining an abscess. There, with prophylaxis, it is 7%, and without it is 40%. This is also a very important question. This was asked last year also, and again this year in INI CET it was asked again. Very important question. You have to remember. We have to remember this. Yes, one that you need to remember the examples of clean, clean, contaminated, contaminated, right? You need to remember those examples which I've covered in the videos. Great. Okay, perfect. And again, I want to highlight one thing to all of you. For FMG students, please, surgery revision is very simple. To revise surgery, you just need to watch the MCQ discussion and the revision videos. Revision videos are 9 hours and MCQ discussion videos are 7 hours. So total 16 hours. These videos, if you can watch them 2 times before your FMG exam and you watch these 3 sessions, that's all I'm asking for. Okay. These videos and these 3 sessions which I'm conducting. If you can watch all these videos 2 to 3 times, you will get more than 26 to 27 questions correct in surgery. Trust me, you will get that. Don't have the FOMO of watching the entire videos now. Now you don't have the time. Just revision, MCQ discussion, and these 3 videos which I'm going to highlight. That's all you need to do. Okay. So when can we use a hand sanitizer? Before examining, after touching the patient surrounding. When the hands are soiled, we cannot use it. We should wash the hands with soap and water. We should wash the hands with soap and water. That is correct. Okay. Right. Perfect. So these are the hand hygiene moments which you need to remember. Okay. Before touching, after touching the patient, if there's exposure to body fluids, or after touching the patient's surroundings, these conditions you can use a hand sanitizer. But please remember 2 conditions when you need to wash your hands: when you visit the toilet, or if the hands are soiled. When you visit the toilet and the hands are soiled, then you have to use soap and water. These are the correct technique of hand washing. This has not been asked in the FMG exam. It has been asked in the INI CET exam. If you can remember it, very good. If not, don't bother too much about it. Okay. Identify the condition, please. Identify the condition. So image-based questions, definitely you should watch. There is an image-based video on my YouTube channel. Please watch that, because at least out of the 35 questions in surgery, at least 20 will have images associated with it. So if you are strong in images, you can answer the question easily and more chances of getting it correct. Carbuncle is correct. This is a carbuncle which is seen in the nape of the neck. And to drain this carbuncle, we will make a cruciate incision. We make a cruciate incision. This has also been asked in the exam. Please don't make a mistake. This is a sebaceous cyst, and the classical feature of a sebaceous cyst is a punctum. The classical feature of a sebaceous cyst is a punctum. This one is an infected sebaceous cyst. You cannot get a sebaceous cyst, no sebaceous cyst in palm and sole. So palm and sole are the 2 places where sebaceous cyst will not form, because you don't have hair follicles there. So don't make a mistake in this also, please. Very important question. This has been asked multiple times. A patient post-surgery develops low-grade fever on day 5 and pain in the calf with pedal edema. What is the most likely diagnosis? Yes, what is the answer here? Very good, excellent. DVT is correct. Very good, guys. DVT is the correct answer. So DVT, you please remember, it is usually unilateral. It is usually unilateral, and in immobile patients who are bedridden, it is bedridden, you can get DVT. Very, very important image. This has been asked at least 5 or 6 times in your FMG exam. These are pneumatic anti-DVT stockings, which are used for mechanical prophylaxis of DVT. You should be able to identify these stockings. They've been asked multiple times in the exam. Yes, very good. Santosh, low molecular weight heparin is the pharmacological prophylaxis. Excellent. Low molecular weight heparin is the pharmacological prophylaxis. Very good. Good. Another very important image which has been asked multiple times are these staplers. So both circular and linear staplers have been asked many times. Circular stapler is used for hemorrhoid surgery. Linear stapler, what has been asked in your exam, is used for Zenker's diverticulum. It is used for Zenker's diverticulum. It is also used for sleeve gastrectomy, which is a bariatric surgery, which is a bariatric surgery. Dhruv, you're absolutely right. Dhruv, pharmacological prophylaxis is better than mechanical prophylaxis. Dhruv, absolutely correct. So circular and linear stapler, these images also you should remember for the exam. Good. This is again an instrument which is frequently asked. This is also every second FMG exam they ask this. Every second FMG exam they will ask this image. We don't fire a stapler on the liver. Sarfaraz, no stapler in the liver. Okay, it will bleed a lot. Monopolar cautery, that is correct. Monopolar cautery. So you should know the images. This is what has been asked from cautery. You should be able to identify monopolar cautery and bipolar cautery. Monopolar cautery looks like a pencil. Bipolar cautery looks like prongs. Looks like prongs. Okay, so you should be able to identify them. Blue is coagulation, yellow is cutting. Correct. Achal, correct. Dhruv, correct. This is a harmonic scalpel. This is harmonic scalpel. This causes coagulation without heat production. This causes coagulation without heat production. That is correct, Ritesh. Bipolar cautery is for vital structures and where there are important nerves. We will use bipolar cautery. We don't use monopolar cautery there. We don't use monopolar cautery close to vital nerves. That is absolutely correct. Okay. This was asked in last year's FMG exam. What is the procedure shown here? You people are very well prepared. You people are answering all detailed answers you are giving. Excellent. Very good. This is simple. This is a tracheostomy. Very good. Tracheostomy. Excellent. Now moving on to shock. So shock, minimum two questions will be asked. Correct. Minimum two questions from shock will be asked. One is from hypovolemic shock. One is either from septic or neurogenic shock. That is the distribution. Minimum two questions you will definitely get. Okay. So patient is brought to the emergency with has hypotension and cold clammy skin. What is the most likely cause? Correct. Hypovolemic shock is the correct answer. Is the correct answer. So one more thing which I want you to remember, hypovolemic shock, of course, I'll tell you some points to remember. Neurogenic shock, that is spinal cord transection. Neurogenic shock, that is spinal cord transection. Please remember neurogenic shock, spinal cord transection, bradycardia plus hypotension. Bradycardia plus hypotension is what you get in neurogenic shock. These two are very important questions. You should Rahul, I will conduct another session if you want description of shock. I will do it on my YouTube channel. I will conduct a video for half an hour, 40 minutes where I'll just talk about shock. You can see my YouTube channel for that. Okay. So best indicator to determine amount of fluid required in shock. It is pulmonary capillary wedge pressure better than central venous pressure. Pulmonary capillary wedge pressure better than central venous pressure. But the best indicator for fluid resuscitation in shock is urine output. So these are two separate questions. Please don't go wrong in them. You should memorize these statements. They have been asked in the exam. Okay. Okay, this was question which was asked your patient with cirrhosis and portal hypertension undergoes upper GI endoscopy and is found to have varices. After a few days, she develops melena and has a repeat bleed. What is the cause of her death? Aishna, you're right. The best endpoint for resuscitation is MVOS, mixed venous oxygen saturation. That is correct, Aishna. Hypovolemic shock is correct because of variceal bleeding, ultimately patient will develop hypovolemic shock. CVP is increased in which shock? This was also asked in your exam. So there's only one shock in which central venous pressure is increased. There is only one shock in which central venous pressure is increased. Correct. Cardiogenic shock. Excellent. Because if the heart is not working, then the preload will keep on accumulating. If heart is not working, preload will keep on accumulating. Excellent, guys. Very good. So you can see here cardiogenic shock. This is cardiogenic shock. JVP is going to be raised. JVP will be raised in cardiogenic shock. Another very important question which you should know for the exam. 70 kg man presents to the emergency following a stab injury to the abdomen. Pulse rate is 110, BP is 90/60. What percentage of blood volume has this patient lost? If you've seen my videos, remember I've given you the example of a tennis match, scoring of a tennis game. That's what I've discussed. So this is which class? There is hypotension here. When there is hypotension, it is going to be class 3. And in class 3, it is going to be 30 to 40%. 30 to 40%. Correct. So this table, invariably, you will get one question from this table. Now, this is the table. To summarize this table, the points which I want you to remember from this table are classes of shock. I've told you scoring of a tennis game. Class 1 is 0 to 15, class 2 is 15 to 30, class 3 is 30 to 40, class 4 is more than 40%. Okay. Then what I want you to remember, in class 2, systolic BP will remain normal. So this is known as the compensated phase. In class 2, systolic BP will remain normal. This is the compensated phase. Now, if you see the question which I gave you, in that the systolic BP was falling, right? Had the systolic BP been normal, it would have been class 2. In class 3, systolic BP falls for the first time. So in any question, if you get a low systolic BP, it is class 3. It is class 3. And class 4, when most of the parameters are unrecordable, that is massive blood transfusion is required in class 4 shock. Capillary refill time is prolonged in all classes of shock except. So whenever you are shown a question like this, if you are given a question like this, I want you to break it down to the basics, right? Let's divide shock into warm shock and cold shock. So everyone, please tell me that cold shock is hypovolemic shock. Hands would be cold or warm. Hypovolemic shock, hands will be cold or warm. Hypovolemic shock, hands would be cold or warm. If there's less blood in the body, hands would be cold, correct. In cardiogenic shock, when the heart is not working, hands will not get blood, so hands would be cold or warm. So in cardiogenic also they will be cold. Cardiogenic also they will be cold. Okay. Here they are asking capillary refill time is prolonged. So if you have cold extremities, then the capillary refill time is prolonged, because if you press this and leave this, it will take more time for blood to come. Okay, it is going to take more time for blood to come. So that is prolonged capillary refill time. So here they are asking it is prolonged in all types except. So they are asking in which type does the patient has warm hands or warm extremities. So warm extremities will be seen in septic shock, in neurogenic shock, and in anaphylactic shock. Septic, neurogenic, and anaphylactic, you're going to get warm extremities. So the correct answer here is septic. I hope all of you have understood this concept. Is this clear? Yes, that is correct. Prachi, another name for septic, for neurogenic and anaphylactic, you can also call them distributive shocks. You're absolutely right. Perfect. Okay. This is also frequently asked in your exam, this question. Reactionary hemorrhage is defined as bleeding that occurs in. Chris, you're right. In late sepsis, you're going to get cold extremities, but initially you get warm. What is reactionary hemorrhage? This is asked frequently in your exam, which occurs 4 to 24 hours following surgery. Very good. So primary hemorrhage is during surgery. Reactionary hemorrhage is 4 to 24 hours due to slippage of knot or dislodgement of clot. Due to slippage of knot or dislodgement of clot. Secondary hemorrhage is after a few days due to infection. So you should remember this, please. Remember this. One question, so two questions I told you I've asked from shock. One question is definitely asked from blood transfusion and its complications, right? One question from blood transfusion and its complications is definitely asked in your exam. So you should know about blood products. You should know about the various complications of massive blood transfusion. Metabolic alkalosis is the correct answer. Correct. Complications of massive blood transfusion. This you should definitely know. Very, very important for the exam. So coagulopathy, it is the most common cause of death. You can get hypocalcemia, hypothermia, hyperkalemia followed by hypokalemia, and metabolic alkalosis. These are the complications of massive blood transfusion which you should know about. Okay, one last question from shock. Identify the type of shock in a patient who has had profuse bleeding and has a low CVP. Low CVP and profuse bleeding, very common hypovolemic shock. Correct. So these were the questions regarding shock and blood transfusion. Three questions. Three questions from shock and blood transfusion. Very, very important topic. Which of the following is not true regarding refeeding syndrome? This has been asked many times. So from nutrition, what is important are the complications of enteral and parenteral nutrition. Are the complications of enteral and parenteral nutrition, and you should know about Ryle's tube. Those are the two things which are important from nutrition. The two important topics which you should know from nutrition. It is associated with hypokalemia, hypophosphatemia, hypomagnesemia. This is true. Thiamine supplementation reduces the risk. True. Strict monitoring should be done when TPN is total parenteral nutrition. TPN is total parenteral nutrition. This is false. The cause of death is arrhythmias and congestive heart failure. The cause of death is arrhythmias and congestive heart failure. So these were some questions from general surgery. I have highlighted the topics from general surgery. Again, I'm showing you the list. These are the topics, important topics from general surgery from which I've covered the questions. We now move on to trauma and burns. Okay, we move on to trauma and burns. Aishna, correct. Most common micronutrient deficiency is zinc. Okay. Important topics from trauma and burns. So you can make a list of this. The important topics from trauma and burns are triage, basics of trauma care, that is ABCD or ATLS, you should know. No PDF of this is going to be sent. I'm sorry. This is a YouTube session. We cannot send a PDF. Sorry. Yes, Vandit, you need to remember child pug score. Vandit, you need to remember child pug score as well. That is correct. Okay, GCS, Glasgow Coma Score, fast, blunt and penetrating trauma, the complications, splenectomy. Tension pneumothorax is asked every time. Diaphragmatic injury, cardiac tamponade, head injury scenarios are asked every time, and 1 to 2 questions from burns are also there. Okay, what is triage used for? What is triage used for? So session will take another 40 minutes to 45 minutes, and yes, the video will be available. Thank you, Nishta. Thank you. Right, what is triage used for? It is to classify priority of treatment. That is correct. So you should know the color coding system. Red is high priority, yellow is medium, green are ambulatory patients. This green was asked in the FMG exam last year, right? Green was asked in the FMG exam last year. Black are dead or moribund patients. So you should know about this color coding. This was a question which is asked twice in the FMG exam. This was asked in your previous FMG exam and the exam prior to that as well. Very important. A patient following road traffic accident is brought to the emergency room with tachycardia, hypotension, and increased respiratory rate. GCS is 7. What should be the next step in the management? Yes, Anamika, blue is the new color code. So moribund patients have been shifted to blue now. Moribund patients have been shifted to blue, and black are the dead patients. You are right. Intubation is correct. Intubation is correct because if the GCS is 8 or less than 8, we have to intubate. So again, ATLS, definitely questions are asked. So in ATLS, we do primary survey and we do secondary survey. Primary survey is ABCD plus life-threatening injuries. Secondary survey is a detailed survey in which all other injuries are seen. Now, in primary survey, ABCD, A is for airway. Airway is always cervical spine followed by airway. Okay, airway is always cervical spine followed by airway. Whenever in doubt, put a cervical collar. This is very important. Indications to achieve an airway in a trauma patient. I will tell you, Tejaswini, I will tell you why not D. So, indications to achieve an airway: unable to speak, GCS 8 or less than 8, coma is there, or severe maxillofacial injury. Then the first thing which you have to do is intubate. Yes, you are saying why not D? So, whenever you encounter a trauma patient, it is A, B, C, D. A is airway. So, first priority is airway. Second priority is breathing. Third priority is circulation. So, circulation, yes, fluids are important, but first you have to take care of the airway, then you will focus on fluids. I hope this is clear, Tejaswini. Now, of course, this is for your exam. When we are actually dealing with the patient, it is teamwork, right? Everyone tries to do everything together. I mean, one person will intubate, one person will give fluids. But for your exam, this is the sequence which you are going to follow. Yes, E is for exposure. A patient presents to the emergency after road traffic accident in which he sustains blunt trauma to the abdomen. What should be the next? What should be the initial step? That is correct. Absolutely. C is the correct answer. We start resuscitation with IV crystalloids. Good. So GCS is extremely important. GCS is asked frequently in your exam. You should know about Glasgow coma score. So Glasgow coma score, please calculate the Glasgow coma score in this patient. A patient who's admitted to the hospital after a road traffic accident is put on mechanical ventilation. He opens his eyes to verbal command and moves all four limbs spontaneously. Okay, opens his eyes to verbal command E3, right? Moves all four limbs M6, and he's been intubated. So the new thing is VNT. So E3 M6 VNT, that is the correct answer here. NT means non-testable. So now, if the patient is being intubated, nowadays, if the patient is being intubated or a tracheostomy is being done, we are going to write it as non-testable. We don't write it as VT, we don't give it a score of 1. It is now written as non-testable. So please remember this update. GCS you definitely need to remember, and EVM, remember the highest response is always noted. We always note the highest response. Whenever we are measuring GCS, we will note the highest response. Okay, so supposing in the right limit is M4 and in the left limit is M5, you will report it as M5. Okay. An adult patient following a road traffic accident presented with subcutaneous emphysema. On auscultation, there is no air entry on the right side. Vitals are unstable. What will be your immediate management? This is definitely asked. No, Ravi, I'm not the admin of that page. My Instagram ID is left-handed surgeon. Is left-handed surgeon. So, adult patient following road traffic accident, subcutaneous emphysema. What will be the first thing which we will do here? Correct. So, insertion of wide bore IV needle in the fifth intercostal space is the correct answer. Is the correct answer. So, this is the latest thing regarding tension pneumothorax. You have to do an E-fast, extended fast is to be done. And extended fast, you will get seashore, barcode, or stratosphere M sign is what you will see, is what you see. And we will carry out needle decompression. And this needle decompression is done in the fifth intercostal space in the mid axillary line. That is the update for adults. For children, it is the same. It is second intercostal space, mid clavicular line. For children, it is second intercostal space, mid clavicular line. Aishna, there is no difference. There is no difference whether cyanosis is present or not. The treatment remains the same. It is irrespective of whether cyanosis is present or not. Okay. A young male develops hypertension and bradycardia after road traffic accident, and on CT he is diagnosed to have cerebral edema. What is the most likely treatment? Abdul, the initial step following blunt trauma abdomen, if the patient is stable, the investigation of choice is CECT, but the initial step will always be fast. The initial step, Abdul, will always be fast. Only if the patient is stable, the investigation of choice becomes CECT. This is correct. You people are absolutely right. Mannitol is the correct answer. Mannitol is the correct answer. Battle sign is seen in. No, we don't give steroids in head injury. Battle sign is seen in. Black eyes or raccoon eyes you will see in patients with anterior cranial fossa fractures. Black eyes or raccoon eyes you will see in patients with anterior cranial fossa fractures. Okay. So one head injury scenario will definitely be asked every time. So head injury scenario, one scenario will be asked out of EDH, SDH, and diffuse axonal injury. Out of these three scenarios, one scenario will definitely be asked. So a patient presents to the ER complaining of worst headache of life. CT image is shown below. What is the diagnosis? So the CT image is this one. Sorry. So CT image, worst headache of life is going to be subarachnoid hemorrhage, is going to be subarachnoid hemorrhage. You should remember that. And I'll show you the three head injury scenarios which are there. I will share the head injury scenarios. No, that is not EDH. That is subarachnoid hemorrhage. I will show you the three head injury scenarios. Okay. I will show you the three head injury scenarios. A patient after road traffic accident has a BP of 80/60. Fast is positive. What is the next step in the management? That is correct. Thunderclap headache is subarachnoid hemorrhage. Exploratory laparotomy, that is correct. This is FAST. FAST, the full form has been asked. It is Focus Assessment Sonogram in Trauma. It is Focus Assessment Sonogram in Trauma. And in FAST, the probe is kept at 4 places. We keep the probe at 4 places. The first place is the epigastrium, then the right hypochondrium, then the left hypochondrium, and then you have the pelvis. That is the correct order in which the probe is kept in FAST. E-fast is extended fast, in which the probe is kept at 6 places. So 4 for the abdominal cavity and 2 for the thoracic region. 2 for the thoracic region. A young patient is brought to the emergency room with complaints of hypertension, distended neck veins, and muffled heart sound. Patient passes away in the emergency room and an autopsy is performed. What is the most likely cause of death? Yes, Dhruv, fast cannot detect fluid in the retroperitoneum. Correct. Focus assessment, sonogram, and trauma. This is cardiac tamponade. Correct. Correct. So, what is this triad which is there? What is the triad which has been mentioned here? Beck's triad. Very good. Excellent. Beck's triad is hypotension, raised JVP, muffled heart sounds. You good. You people are very well prepared. Good. Keep up this hard work. Keep on revising. I think so. You people are answering very well. These are the kind of questions which will be asked. You need to revise them again and again. Revision is the key. Just by reading once, you will not be able to clear the exam. So utilize the next 40, 45 days. Whatever you've done, keep on revising it. Keep on revising. That is important. A patient presents after blunt trauma abdomen. Patient is complaining of left upper quadrant pain and the vitals are unstable. Left upper quadrant pain and the vitals are unstable. What is the next step? Yes, revision videos and MCQ discussion videos are enough. In my MCQ discussion videos, I've covered up 3 years of FMG papers as well. So please watch the revision and the MCQ discussion videos. That and these 3 videos are more than enough for surgery. Surgery, you don't require more than 4 or 5 days. That's it. Laparotomy is the correct answer. That is correct. We will do laparotomy here. A patient following road traffic accident presents with pain. The resident examines the child and finds tenderness in the left lumbar region, but the vitals are stable. What is the investigation of choice? So, if the vitals are stable, what will be the investigation of choice? CECT. That is correct. CECT. CECT is the correct answer. Is the correct answer. I told you this. What do we do? This urethral trauma has become very important. Last 2 FMG exams, this time's INI-CET, last time's INI-CET exam, there have been questions from urethral trauma. A boy with perineal injury comes, there is blood at the tip of the meatus, the child has not passed urine. In the previous question, why not fast? Fast wasn't there in the options only. And the vitals are stable. So why would we do laparotomy if the vitals are stable right now? First, we'll assess the extent of injury. Correct. We wait for the bladder to distend and then give a trial of micturition. Foley's is contraindicated. Very good, Shantanu. Good, Prince. Foley's is contraindicated. That is what I wanted to know. So whenever there is suspected urethral trauma, if there is a full bladder, we will do suprapubic catheterization. If the bladder is not full and there is no discomfort, we wait for the bladder to fill and then give one trial of micturition. We give one trial of micturition. That is correct. The investigation of choice is RGU. Saurabh, I didn't understand your question. Can you ask your question again, Saurabh? The question in which vitals were unstable. Okay. That is correct. I'm sorry. Yes, you are right, Saurabh. Here the answer will be fast followed by exploratory laparotomy. That is correct. This question it will be fast followed by exploratory laparotomy. Absolutely. You're right, Saurabh. You're absolutely right. Here the next step they are asking. The next step will be fast, and following fast, then exploratory laparotomy. Correct. Yes, absolutely. I'm sorry. Yes. They are asking the next step. They ask the next step in the management. So the next step in the management would be fast. You people are absolutely right. The next step in the management would be fast here. It will not be here. Next step they are asking, it will be fast only. Correct. Okay. 50-year-old lady meets with a road traffic accident after traveling back from her office. Which of the following is the most commonly associated with the lucid interval? Correct. EDH is correct, extradural hemorrhage is correct. So out of these three scenarios, we will definitely get one. We will either get EDH or we will get SDH or we will get diffuse axonal injury. Out of these three scenarios, one is definitely asked in the exam. EDH, SDH or diffuse axonal injury, this is definitely asked. EDH is seen in patients young when there is a high velocity impact. It is arterial in nature. Middle meningeal artery has been asked and lucid interval. No wonder if you watch the revision videos of edition 5, you don't need to watch edition 6 videos. Correct. That is the story Bala, which I have told in the videos. Army man who sustained a fall. That is correct. Subdural hematoma, you will see it in elderly patients, and this is venous in nature, and you will get concavo convex. Concavo convex. Tawfiq, I didn't understand your question. Can you please write down your question? I'll answer it. The most severe is diffuse axonal injury, and you get a shearing force between the gray and the white matter. The patient will be in a state of coma. NCCT will be normal. Yes, correct. Oral cancer and breast cancer stagings. That's all you need to do, Achal, for FMG exam. So that is because of chronic contusions. So dementia pugilistica is because of chronic contusions that can give rise to dementia pugilistica. That is also again I've highlighted about this for American football as well. Repeated traumas, repeated minor concussions can give rise to long-term dementia and memory changes. If you have seen edition 5 videos, you don't need to do edition 6 revision videos. Just revise the edition 5 videos. Tawfiq, laparotomy would be the answer after fast. First we will do fast and then we will do laparotomy. Then we will do laparotomy. Okay. So these were the head injury scenarios which you need to know. Okay, I'll just explain that. Let me just finish this question and then I'll explain that, please. So a 39-year-old man get hits by a truck while crossing the road. He is rushed to the ER. His GCS is 8/15. Pulse rate is 84. NCCT is ordered. Image is normal. After 12 hours, GCS is not improved. Diffuse axonal injury. Correct. Okay, so you were asking about when to do. That's a blunt abdominal trauma. In a patient with blunt abdominal trauma, if the patient is stable or if the patient is unstable, if patient is stable or unstable, the first investigation in both the cases will be fast. The investigation of choice in a stable patient will be CECT. Here it is fast only. Now, if fast is positive, if fast shows that there is a collection, then we will take up the patient for laparotomy. Then we will take up the patient for laparotomy. Is this clear now, Tawfiq? Tawfiq, is it clear? Two people were asking about this. Is this clear, everyone? Yes? Okay, great. What about stab injury? Okay, Yashu, I'll explain stab injury as well. So if there is a penetrating trauma to the abdomen, if there is a penetrating trauma to the abdomen, if it is superficial to peritoneum, if it is superficial to peritoneum, we will suture and do CECT. We will do suture and CECT. Okay. But if peritoneal breach is there, if peritoneal breach is present, that means the patient has peritonitis or omentum is out, then in this situation, no investigation. Now we don't do any investigation. We straight away take up the patient for laparotomy. Now we are not going to do any investigation. We are going to do laparotomy. Okay, correct. Is this clear? Blunt and penetrating trauma. You people had a doubt. Is this clear now? Propofol, if you've seen edition 6 main videos, do I need to watch revision videos? No, then you just see these three high yield videos which I'm going to cover. Just see these three videos. That's it. If you watch the main videos and if you revise the notes, this we've already done. Okay. This was a question which was asked in your FMG exam. DPL, Anju, we don't do DPL now. DPL is usually done when fast is not available, right? If fast is not available, then only we do DPL and blunt trauma. A chronic smoker undergoes major surgery under general anesthesia. Suddenly, patient's vitals become unstable and breath sounds are not heard on the left side. Most likely causes tension pneumothorax. We've already discussed how to manage this. Okay. Now you people can answer this. I've told you the concept. You can answer this. Correct. Tension pneumothorax. Yes, now answer this one, please. I've explained you the concept. Please answer everyone. Correct. C is the correct answer. So wound superficial to the peritoneum. We are not going to do laparotomy. This I've all explained to you. This is what I just explained the workup to you. What is the most common organ injured in seatbelt syndrome? So most common organ injured in seatbelt syndrome. Mesentery. That is correct. Mesentery is the correct answer. So this table also you should remember for the exam. Most common organ injured in blunt is spleen. In penetrating trauma, it is liver. Gunshot wound, it is small intestine. Seatbelt syndrome, it is mesentery. Deceleration injury, it is DJ flexure. And overall, it is spleen. So you should remember this table as well. Okay. This question has been asked many times. So that was the trauma. I've told you the important questions which are there. Moving on to burns. Burns, invariably, 1 to 2 questions will be there from burns. So review the image and suggest which degree burns has the patient sustained. Very good. Second degree superficial. Why? Because of the blister which is there. Because of the blister which is there. Very good. This is third and fourth degree burn. This is a third and fourth degree burn where you can see that the burnt area is black and charred. Burnt area is black and charred. This is a third and a fourth degree burn. What is the most important factor that predicts mortality in thermal burns? Most important factor that predicts mortality in thermal burns. Yes. So the correct answer here, which predicts mortality in thermal burns, is inhalational injury. That is the most important factor that predicts mortality in thermal burns. And this is another thing which you should remember for the FMG exam. The causes of death following burns. The most common cause, immediate, is asphyxia more than neurogenic shock. I will cover Parkland's formula. Just 1 second, I'm covering that. Immediate is asphyxia more than neurogenic. Early in 1 to 3 days is hypovolemic. Late is septic. Overall is septic. And the most common organism which causes death in burns patients is Pseudomonas. So Burns resuscitation, the new Parkland formula, for adults, it is now 2 into body weight into total body surface area. So earlier it was 4 into body weight, now it is 2 into body weight into total body surface area. That is the new Parkland's formula, which you should remember. 2 into body weight into total body surface area is the new formula. Okay, we don't calculate using 4, we calculated using 2 now. Okay. Now, if there is a child who's less than 14 years, then the formula is 3 into body weight into total body surface area. This actually for the FMG exam, you don't need to remember. You just need to remember that the new Parkland's formula is 2 into body weight into total body surface area. Everything what I'm mentioning here, all this I've explained in detail in the revision videos. Okay, so instead of asking for the PDF, if you see the revision videos, the PDF has been emailed to all of you for the revision videos. Just watch that PDF, just read that PDF and watch the video. Electrical injury, it is 4 into body weight into total body surface area. For electrical injury, it is 4 into body weight into total body surface area. But please remember that the new formula is 2 into body weight. Yes, the video will be available, same link with which you joined. You can click on that link and you can see the video. Wallace rule of 9, you need to remember for the exam. You need to remember Wallace rule of 9. It is extremely important. Wallace rule of 9, you need to remember. Bed sores are very frequently asked. Usually the question is, what is the grade of bed sore shown in the image? So you should know that bed sores are formed when the pressure is more than 30 millimeters of mercury. That is when bed sores are formed. And you have to identify the grade of bed sore. So whenever you are given an image of a bed sore, if you're shown an image of a bed sore and they're asking you the grade, the answer will be grade 4. If you are being shown the image, the answer is going to be grade 4 here. Okay, grade 4 will be the answer. Here you can see the muscle. You can see the muscle. It is grade 4. The most common site is the ischium. The most common site is the ischium. Staging of pressure sores: 1 is epidermis, 2 is epidermis plus dermis, 3 is subcutaneous tissue, and 4 is when you have muscle layer involvement as well. When you have muscle layer involvement as well. Okay. So if you're being shown an image, it will be a grade 4 bed sore. This was asked in the FMG exam. A lot of students got this wrong. Very easy question. Chris, because it is very difficult to make out on the image grade 2 or 3. To differentiate between grade 2 and 3 on the image is very difficult. So they will not ask such a confusing question. Until unless you actually examine the patient, it is very difficult to make out between 2 and 3. Yes, so this is an aberration and you clean and leave it open. Correct. This is an aberration, you clean and leave it open. Very important question, whether you want to call it a pathology question or a surgery question. What is the correct order in the normal phases of wound healing? The correct order in the normal phases of wound healing. So you have hemostatic, inflammatory, proliferative, and remodeling. That is correct. So first there is hemostasis, then inflammation, then proliferation, then remodeling. Another very important question is regarding keloids and hypertrophic scar. That is also frequently asked in the exam. After resection of a lipoma over the neck, a patient develops an elevated scar with itching. The scar is restricted. It is restricted to the region of the scar. That is correct. Very good. Hypertrophic scar. So keloid will grow beyond the boundary of the scar. Hypertrophic scar is restricted to the region of the scar. These are the differences between keloids and hypertrophic scars. You should remember this. They have been asked in the exam frequently. So keloid grows beyond the boundary of the scar. Hypertrophic scar remains within the boundary. Keloid does not settle with time and pressure. Hypertrophic scar settles with time and pressure. Remember, I told you the example that I got a split webbing while taking a catch and I developed a hypertrophic scar. But with pressure and time, that scar settled down. Keloid does not settle down. The most common site is the sternal region for keloids, and it is more common in dark-skinned patients. Intralesional triamcinolone is the treatment. Skin grafting is a very, very important topic. Every year there is one question from skin grafts. Skin grafts, you should definitely know. And this instrument has been asked many times in the exam. Aishna, I've already told you, management is intralesional triamcinolone for keloids, and for hypertrophic scar, it is pressure. Yes, correct. And what is this instrument known as? What is this instrument known as? Humby's knife. Very good. Excellent. Humby's knife is the correct answer. Skin grafts, you should definitely know. Split thickness skin graft is known as Thiersch graft. Full thickness skin graft is known as Wolff's graft. In split thickness skin graft, it is epidermis plus parts of dermis. In full thickness skin graft, entire epidermis plus dermis is taken. Split thickness skin graft is usually taken from the thigh or the buttocks, and full thickness skin graft is taken from the supra or the infraclavicular fossa, never the axilla. Never the axilla. This is also a very important question from the FMG point of view. Lots of times this question has been asked in the exam. Lots of time, correct. From an identical twin, it is an isograph. Very good. It is an isograph. So autograft is same person, isograft is identical twins, allograft is same species, and xenograft is different species. Xenograft is different species. Okay, so that brings me to the end of this first video. We've done general, we've done trauma and burns. I've highlighted the important topics. Okay, now again I'm saying just the revision videos, just the revision videos and the MCQ discussion videos, and these three videos which I'm going to highlight, okay, plus one image based video which is there on my YouTube channel. There is one image based video which is there on my YouTube channel, which you should watch. All the 3-year FMG solutions are there on my YouTube channel. So previous year questions, you can do that much. Just this much is enough for surgery to get more than 30 correct. And you just need to put in 4 to 5 days for surgery. That's all. I'm not asking for much. 4 to 5 days would give you almost 30 questions for the exam. So please keep on revising. Okay. Next session would be next month. You would be informed. We'll do it in the early half of December. You would be informed about it. These three videos, this was video number 1, these potential questions. You'll have the next video, we will do endocrine and part of GI. Then in the third video, we will do hepatobiliary, vascular, and miscellaneous. So these three videos, okay? Keep on revising. If you have any doubts, you can send it to me on my Instagram ID. It is left-handed surgeon. Again, I'm saying keep it very simple. Don't complicate things at this juncture. If you have not done any subject, just do the revision videos and the MCQ discussion videos. Don't try to do a lot of things for any subject which you haven't touched till now. Any subject, if you are having problems, just the revision and the MCQ discussion videos and keep on revising. Aishna, what forgettables are what you are forgetting. The only way to get rid of forgettables is to revise. Medicine also same thing. Revision and MCQ discussion videos. That's it. And last 3-year papers. Last 3-year paper solutions for FMG medicine. That's it. Nothing else. Deepika, it's not possible for me to do all the thing today. We will divide it into 3 parts. You people revise this, you will get all the 3 videos. That's a promise from my side. You will get all the 3 videos. Okay. All the best, guys. Keep preparing. If you have any doubts, just ping me on my Instagram ID. All the best. Keep revising, keep solving MCQs. Don't sleep without solving MCQs daily. At least 50 MCQs you people should be solving on a daily basis. You're absolutely right, Nishta. So that FOMO thing should not be there. If you can just see the revision videos in the last few months and you can revise them again, that would put you in a very good position. Okay. All the best, guys. Thank you very much. Thank you. Thank you.